Good afternoon and welcome to the Senior Hour, which is sponsored by Providence Holy Cross Medical Center and Comfort Keepers in Home Care. I'm Barbara Cochran with my co-host,
Dr. Thomas Pilecki.
on your hometown station, 98.1 FM, AM 1220 KHTS. This is a show for, about, and by seniors, giving information to enhance one's quality of life. And speaking of quality of life, our two guests this afternoon are from Providence Holy Cross Medical Center, and they are nurse practitioners. I knew I'd get it right one way or the other. Sandra Wallenham and Hannah Doherty. Welcome. It's good to have you, and you've been here before a couple of times.
Yes, thank you so much for having us. We're excited to be here.
Yes, so what are we going to be talking about today?
I think we're going to be talking about palliative care, and we work with the palliative care department at Providence Holy Cross in their in the inpatient side of things. So,
Okay, so what got you both involved in being nurse practitioners and getting into the medical field?
Yeah, sure. So we'll explain a little bit about what a nurse practitioner is. A nurse practitioner is a master's prepared registered nurse who is now able to work directly under a physician and with a physician, and we're able to diagnose, treat, and prescribe medications. And so we work in the area of palliative care, and we work inpatient. So our degree specifically has trained us to work with acute illness with adult patients in the inpatient setting.
Oh, so what got you involved to begin with?
Yeah, so I think I've been a nurse for 6 years, working in like a liver transplant ICU, and over the course of my nursing career, I've seen a lot of patients, go through a very complex disease process and require palliative care. And this is something I've always wanted to, understand more about and learn more about, and how I can really help patients clarify their healthcare wishes. And so, I went back to school to get my master's, and I'm almost finished to become a nurse practitioner. And one of the rotations I really wanted to learn more about is palliative care. And so I'm here, and I've been working with Sandra and Dr. Kalani at Providence Holy Cross Medical Center. And it's been a great experience to really work with patients and their family members to, really understand how we can make that transition into managing their pain and their symptoms, and just really identifying those goals at the end of life.
So what got you interested in doing this? Something must have happened in your lifetime.
Yeah, so coming from like a medical family, so my dad's a doctor, my mom's a nurse, they both work in the ER, and just kind of being exposed to that medical background at such a young age really left an impression on me about wanting to make a difference and how to best do that, and that's why I chose to do nursing. And then, wanting to further my education and my career in order to make additional impact in this field, that's what led me to want to go back to school to be a nurse practitioner.
Oh, so what caused you to be interested in this?
Sure. I kind of have a similar experience as well. My mom's a nurse, and I decided to become a nurse after school. I originally had a bachelor's degree in psychology, and I thought I wanted to go on to be a therapist. But then I transitioned after that bachelor's degree and did a second bachelor's degree in nursing. Once I graduated as a nurse, I started working in oncology. And I saw the need there in oncology, patients that were very ill, that didn't know a lot about their disease and what's going on with them. And so I decided I wanted to further my career and become a nurse practitioner. And through that, I found my way to palliative care. So I've been working in palliative care now for the last few years.
Very interesting.
Yeah.
So the 300-pound gorilla in the room is the word palliative care.
Right.
And like so many things in healthcare, it's largely misunderstood by most people. Mm-hmm. Until I started interviewing Dr. Kalani, even I'm in the field.
Right.
And I had misconceptions about palliative care. And by the way, my name's Tom, and my mom's a nurse too. It's like the nurse mom,
Everybody's
the
mom's a
nurse mom
nurse.
crew.
It's in the family.
So,
Yeah.
keep it all in the family.
Yeah.
So yeah, that definitely has a strong impact on the kind of work that you're going to do in the healthcare field. I believe that nurses are the heart of medicine, regardless of what alphabet soup comes after your name. It's all about nurses are the heart of the whole system. But palliative care, for most of us, I gotta say, is often confused with hospice.
Right.
Like it's end of life, like
Yeah.
let's angel of death kind of stuff.
Right.
So can you just, I know now, but I'm sure a lot of people still don't know the difference. So I'm going to ask you, because I know you know the answer.
Yeah.
What's the main difference?
Yeah. So still a lot of people get really scared when we come in the room and when they hear palliative care. But really, palliative care, we're a medical specialty, like any other medical specialty, like a kidney doctor, heart doctor. But we get consulted when a patient has a serious or chronic illness, and there's more going on with that patient, and they could really use an extra layer of support. So we really do whole person care when a patient has a serious illness. We do symptom management. We look at the psychosocial. We look at the spiritual, and we also do advanced care planning. And we look at who this patient is, what their values are, what's going on with them medically. And we work with the different providers to make sure that this patient is being treated medically the way they want to be treated according to their values.
Yeah, that's awesome. And it's a shame that that kind of advocacy isn't just standard practice. Like you need a specialty in order to get to that place.
Yeah,
I mean, that should be in the ER.
Yeah.
And that should be everywhere.
Yeah, and the way we educate the nurses and physicians that we work with is everyone really does primary palliative care, meaning that we, take care of the patient and their family and we look at them as a whole person. But when things are getting a little bit more complex and there needs to be more conversation, that's when we come in and we do specialty palliative care. So I think we're getting to that point where everyone's really practicing palliative care at, at least the standard of
The
care
triage level.
Yeah.
Triage palliative.
Yeah.
I just created a new program.
Yeah.
Now put it to work.
There you go.
Yeah.
That's great. Okay, so what's a typical day look like for you?
Sure. So we can talk a little bit about that. So we work in the hospital. So there's different, so palliative care can be in different settings. We work in the hospital. There's also a home-based palliative care group that works outside of the hospital and goes to people's homes. But we work in the hospital, so we're a consult service, like I said. So we have a list of patients that we've been consulted on from the either primary physician, attending physician, or one of the specialties, sometimes oncology consults us in. So we have a list of patients. We review our patients together. We split up the list. And as providers, Dr. Kalani sees the more complex patients. And then as nurse practitioners, we will see the other patients on our list. And we go room by room. And we, review our patients, see what they need, do symptom management, support them, and really meet them where they're at for what they need for that day.
Yeah. Outside of mainstream, outside of the hospital setting, and before I was even aware of nurse practitioners or palliative care, which maybe I can ask, like, when did all this start? Like, when? This hasn't always been this way.
It hasn't. So we're a newer medical specialty. We came about maybe like 30 or so years ago. And honestly, I think it kind of came to be because patients are living longer. They have more serious illness. They have more chronic illness. We have more treatment options for people. So it becomes quite confusing, even for, some people in the field, what different treatment options, what they mean for their lives. So that's kind of where we came about. And And really, we were put on the map because all those years ago, a study was done with lung cancer patients, patients that have advanced lung cancer, and they randomized those patients into two different groups. One got standard of care treatment, the other got standard of care treatment with palliative care. And at the end of that study, they actually saw that the patients that had palliative care actually lived longer than the other group. So the benefits there when we see patients are very sick and when we provide them with quality of life and symptom management along with their standard treatments, we see that it really benefits them. So, so that's where I think, we've really come into the forefront of medicine.
So
and we
what
do a
does
lot
that
now.
mean, quality of life? What does that mean to you?
So I think obviously everyone has their own definition of what they want their quality of life to be. I don't think that's something we can, verbalize for them, like my quality of life and what I want in my healthcare goals, or just, what I want to have done in life may be different for yourself or for Sandra or for you. And that's kind of for something for you to think about and internalize and maybe talk with your family about. But, for example, someone's quality of life might be that they want their pain to be more under control and managed so that they can, see their, daughter or son get married or, make it to that event, be able to work with physical therapy so they can make it to that event, be able to meet these like little milestones before saying they don't want any further treatment. So it kind of just depends, what that individual has decided or determined for their life to be, and just fulfilling those goals, as I mentioned.
So do you help them fulfill those goals?
Yes, we do, and we have conversations, sometimes difficult conversations with patients and their families to really have these like open and honest meetings about what can we do to truly understand, what your wishes and wants are. And I think, it's been really enlightening and very fortunate to have these opportunities because, like, we're making a difference, having those conversations and helping these patients fulfill their goals, And I feel like what Sandra had mentioned with that study, maybe it puts the patient or the family at ease knowing that finally they're able to achieve these goals.
Interesting. Very interesting.
So my understanding of the word itself, palliative, outside of the misconceptions out there, is pain management. Am I wrong in that?
Yeah, so palliating someone is kind of easing their way, addressing their symptoms, not only pain, but also spiritually. I mean, things can be going on with people. I mean, they're going through some of the hardest times of their lives. So just really, like I said, meeting them where they're at, physically, spiritually, socially, all of those things, to really figure out, like Hannah said, what their goal is and how we can help them achieve that goal.
Yeah, and that is the interesting thing that's hard to quantify because there's not a one-size-fits-all answer.
There's not.
Just like so much. There's a lot of, in chemistry you'd call it titration. Like there's varying levels of what's important.
Yeah.
And it's not going to be the same for each person. So
it's
there's never a one-size-fits-all. And I believe that is where the art of nursing comes in.
Correct. I mean, you have the same two patients with the same disease and the same prognosis, but they might want something completely different based on who they are. And that's where we come in and really figure that out.
Yeah.
Well, do you handle any psychological symptoms?
Yeah, we do.
You're educated to do that also.
Yeah.
So you're basically psychologists. Also.
Yeah. We're a little bit of everything, I think,
It
just
sounds like it.
whatever's needed at that moment. I mean, we could be the therapist, we could be, the medical professional, but we figure out what they need and where they're at, and then we consult other people in to help us address that specific need. So, so yeah, we really do whole person care.
You're a jack
definitely.
of all trades.
We like to think so.
But not a bartender. That's
Yeah.
frowned upon.
Right.
Except at home.
Yeah.
You can do what you want to at home,
Right.
but not on the job.
That's right.
But you really do get involved at a level that, as as necessary as the doctors, the specialists, the people that are in that life or death situation. You get involved with your patients in a way that they never will.
Yeah.
So how do you protect yourself
Right.
against that? I mean, I know there's supposed to be this professional detachment, and I know that's a bunch of BS because it only goes so far
Yeah.
if you're doing your job.
And I think probably, Hannah can attest to this too. I think every nurse at a part of their career needs to go through that, where they understand that now they need to have a little bit of a barrier up, where not every single thing is affecting you in such a deep way that you're not able to do your job and be professional. But at the same time, you need to be able to empathize with people and not become so cold. So I do think sometimes things will affect you, certain situations will affect you more than others, because we're all human. And if we lost that, we wouldn't be able to do our job well. But just understanding that, we're not God. What we're doing is just listening, communicating with people, figuring out what their goal is and what's important to them. And that might not be, what we agree with, but it's their life and it's their goal, and helping them reach that goal. And continuing to have conversation with them and realizing that, this is their life and it's our job just to ease them through, but it's not our job to have a certain outcome at the end. So I think understanding
Detach
that.
from the outcome is a good strategy in any field.
Yeah, for sure.
Yeah.
That would be very hard to do, I would think.
It is a challenge.
I bet it is, because if you're with a patient and you hear all of their life story, mostly, and see the family members there, and that has to affect you in a certain way.
It does.
Because you think, oh, gee, that happened to me. Oh, that was horrible.
Yeah.
I had forgotten all about it, or put it away, And then here it is again, right in front of you.
Right.
So, well, are you, do you have access to psychologists also in your trade, if you run into something like that, someone who you can talk to?
Yeah, I think that in medicine overall has gotten better at the mental health aspect of things, and those, services are more
They're more available.
If needed. So, and I think that's a good thing that's become destigmatized, and so everyone could kind of, because these things are hard, and you need to talk to someone sometimes. So, and that's okay.
Yeah, I would think it would be extremely hard.
Yeah.
I know it was for me when I was losing my husband.
Yeah.
Because I was there 24/7,
Right.
even though I had help.
Yeah.
But still, watching him go through all of that pain and discomfort, it had a big effect on me. It really did. And thinking, gee, is there something I could have done better? Because a lot of guilt comes in there.
Yeah,
And I think that happens with any married couple who loses a spouse.
For sure. And I think that's something that we do really uniquely, is caring for the caregiver, where sometimes in medicine we're so focused on the patient, but our team really looks at the caregiver and the whole family and really supporting.
The whole
'cause
situation.
Yeah, it's very hard. Yeah, so.
Wow. That's a heck of a job you have.
I think it's good though, like you have the team, right? You're not by yourself,
Right.
and there's people who can you can rely on and have these conversations about. And I think once you leave the hospital doors, you know that you're going to go home, and kind of leaving that, and you come back and you go back to that work setting, and you kind of separate the two, and work is work and home is home. But there is obviously it's one thing to say and one thing to do. So
It must be feel very good to go home to family
Yeah.
and not have to worry about the person that you've been taking care of during the day, or whenever you do,
Yeah, it makes you
you
grateful.
know, and know that somebody else is in there after you leave to take care of that person. So you literally have two lives, really. Your life practicing your career and your life at home. And I would imagine it would be very hard to separate both of them completely. We have a subject to talk about now. You want to continue?
Sure, sure. I think we were going to talk a little bit about palliative care and the differences between palliative care and hospice.
Yeah.
If I'm
So
not mistaken.
from scratch, like imagine you're explaining to somebody who just landed on the planet, what is palliative care? Because I think in explaining it that way, you're able to skirt the misconceptions, the prejudices about the word
Right,
itself. So I never heard the word before. I have no idea. What is it all about?
Yeah, so really at its basis, we're supportive care, we're whole person care. So we are a medical specialty that's coming in when you or your loved one has a serious illness, and we can provide that extra layer of support for you. We could do symptom management. We could address any issues you might be having, any questions that might come up about your disease, about where you're at in your medical journey, and really talk about the goals for your care. And do advanced care planning and make sure that your values are being addressed in your medical care. So that's really what we do. And it's under the umbrella, of hospice care, but really hospice care is when now your main goal is not for aggressive curative treatments. Your main goal is just for symptom management, end of life care, and to address quality of life. And you're not going to be doing any more aggressive treatments, and you're transitioning over to that level of care. So it's very different.
Yeah, and there's even a lot of even professionally, a lot of misunderstanding about hospice. I know hospice care can last years. Years.
What
Now
do
it's
you mean
typi-
last years?
typically not expected to last years because there are some criteria.
Right.
The hospice type of treatment, the hospice care,
So how do you know when to go from palliative to hospice?
well, there you go.
Sure. So like I said, when a patient has palliative care on board, the main goal is still for aggressive curative treatments and medical treatments. So they could be receiving chemotherapies, they could be receiving dialysis, but they're dealing with a serious illness that we should be involved so we can continue to talk to them about their goals, continue to follow them, do symptom management, and make sure they have a good quality of life. And then a patient progresses along, you continue to have conversation about where they're at and what their goals are, and they get to a point now where there's really not a lot of treatment for them for their cancer, or they've progressed to a place where now really the best treatment we have for them is end of life care, symptom management. They have a prognosis, so their disease has a 6-month or less prognosis. So now they're in a more terminal state of their disease and their illness, and we would recommend transitioning over to hospice care.
But
So-
it doesn't always work like that.
Yeah,
Because those darn diseases haven't read the books.
It's true. It's true. So we, say you qualify, your disease has a 6-month or less prognosis, and you're not going to be doing any more life prolonging treatments. So now you qualify for hospice care. But sometimes, like you said, once a patient's on that level of care, now we're treating all of their symptoms, we're treating them for their comfort, and they simply live longer than we had anticipated. So hospice care can be renewed on a 6-month timeline by a physician.
Right. And sometimes people go into remission.
Yeah, yeah. And sometimes they can even graduate off of
Yeah.
hospice care and, go back to their standard of care treatments.
Yeah.
So everyone's different. Everyone's an individual. And like you said, people don't read the book. So that's, where we come in, where we treat every single person as an individual. And we see how it goes.
Yeah.
So you learn about the person you're taking care of. You learn what makes them tick, how they feel about things.
What they need.
And and do you have conversations with them
We do.
like that?
We do. I mean, sometimes they're so ill that you're having the majority of the conversation with their family.
Right.
But yeah, if the patient is able to have a conversation, we definitely want to, have that conversation with them and make sure that they're being treated the way they want to be treated.
So do you go into their homes or do you just do at the hospital?
So, but there is a home-based palliative care group
Right.
that does go into people's homes and treat outpatient, in the outpatient setting.
So I got a question. I don't know if it's in your boat because you're mostly hospital and it's usually a pretty serious illness.
Yeah.
Big increase in dementia. Does that ever enter into your world
It
there?
does. It does.
So that is probably, I think it's more scary for the family and more impactful for the family than something like, oh, you've got this, or you've got 6 years to live. Evil.
Yeah.
Like it's just the worst. So what has been your experience with that in the hospital setting?
Yeah. So in the hospital setting, we do see a lot of patients with dementia. Specifically, our hospital is in a geographical area that there's a lot of nursing homes around. So we do see a lot of patients with dementia coming into the hospital from the nursing home and dealing with the ender stage symptoms of dementia, which is like not eating, not drinking. And now because they're not eating and drinking, they'll get infections and things like that, and they'll come into the hospital. And then we have to have a lot of conversation around artificial nutrition and a lot of education around the progressive nature of dementia, how that disease progresses and how it eventually progresses to a point of not eating and not drinking, and how things like feeding tubes are not recommended at that point of things. So dementia kind of looks like a lot of education, a lot of support for the family, and then having conversations around, life prolonging measures versus just focusing on comfort and doing hospice level of care.
Yeah, because I've had experience with really nasty cancers disappearing.
Yeah.
You don't see that so much in dementia.
No. So kind of just really educating family that this is a chronic progressive disease. There's no cure, and it will progress to this point. And, the best case scenario is we catch a patient before it's progressed to that point.
Yeah.
And we are able to educate family around this disease and the way it progresses and kind of guide them. But sometimes, we catch it at the very end.
Yeah.
But really, that's a big part of our job is really taking care of the family and supporting them in what they need and caring for this person with a progressive, terminal illness that progresses slowly.
Yeah, it's rough.
yeah.
It's rough.
Yeah.
And much harder on the family. So that's where the nursing really comes in. So let's talk about being a nurse practitioner. So I think, as I said, raised by a nurse is the heart of healthcare by far. And then you
But
take
they're
it.
the ones who do all the work.
Yeah.
They really do. Says, oh, this, and this, and your blood pressure's okay, and have a good day. See you later.
Yeah, well, you need everybody.
And that's what happens with doctors.
You need the specialist. You need the specialist there to
Absolutely.
make, the intervention. But the nurses, as you said, do all the work, right? So, and then nurse practitioners kind of like that in between, not, and I hate to say this, I don't even feel comfortable saying this, not just a nurse, but almost a doctor, right? So, what's that all about?
Yeah, so I think kind of similarly to where the need for palliative care came about, the need for nurse practitioners came about when patients are living longer, diseased, people are living into very elderly years, and there's a lot of patients, there's a lot of people that need care. And that's where I think as a nurse practitioner, we really come into the forefront. Physicians are, highly trained, highly educated, and very specialists. But then nurse practitioners are coming about to kind of help physicians fill that need with all of these patients and patients that are a little bit more chronic. And where physicians can more focus on maybe the more acute issues and something that's a little more complex. So nurse practitioners are trained as a nurse in that kind of holistic perspective, but they've been trained as a provider. So now we've been trained in, disease diagnosis and treatment, and we can really help with that need and help, doctors be able
So,
to.
is there a doctorate in nursing?
So there is a doctorate in nursing, yes.
Yeah.
Yes.
So
yeah.
that's the next step, yes?
That's the next step. And it's and we're master's prepared, and the doctorate prepared can either be like a PhD where it's more like research or a doctorate in practice where it's still a nurse practitioner, but they're trained as well in like, quality,
It's more like clinical based.
yeah,
For like
QI and stuff like that, yeah.
So, Hannah, how was it with you growing up in the medical profession? Because you said your dad was a doctor and there's medicine in your entire family. How did that affect you as you were growing up? Did you see your dad less than you would have normally? And
Yeah, no, I think that's a great question. Both like my mom's a nurse, my dad's a doctor, and they both worked very hard. Growing up, I have multiple brothers and sisters, and they worked very hard for us to get where we are at today, currently, for all my siblings and I. But they put as much dedication in their work for caring for patients as they did, obviously, at home. And I think, as you previously talked about before, like making that separation of like work is work and home is home. But I think in terms of determining like why I wanted to go into nursing or, further my education to be a nurse practitioner, when I kind of have both of those role models at home, right, of a
Right.
nurse and a doctor, I wanted people to really make that connection with patients, like be there in that moment, what your needs are, how can I address them, like how can I be your biggest advocate. And then again, going back to school to get my nurse practitioner degree as a master's level, it's like, kind of having that foundation, but now again, having the increased knowledge base to be able to diagnose, have like increased interventions to prescribe medication, and work with this multidisciplinary team to really optimize patients and improve their quality of care.
well, that that must have affected your family life, your home life, your friendships. That must have been very interesting. Explain that. How was that during your growing up? As I know you're very young, but still you have had a family and you're growing up in a family and having friends. So how did relationship with friends and family?
I don't think it had like a big effect. I mean, growing up, I was like every other child. We played soccer, sports, I had like my aunt's help or like neighbors' help, and we had like our parents still went to our games and everything. But it's kind of like finding that balance because like I'm one of five, so not everyone wants to do the same extracurricular activity.
Right.
So really, having this strong community and resources to help, ensure that you can just, have a good childhood, and I think that's
That's
really
good. So you feel like your parents provided that
Yes,
for you.
yes.
That must have been very hard on them.
Yes. And they're still working, so I'm like,
They're doing a
So
good
do
job
you
still.
have a family yourself?
I do not
No.
know.
Not yet,
No.
but you will.
One day.
That's terrific. That's terrific. Wow. I cannot imagine going through that kind of rigorous training. It must have been very, very hard on you emotionally as well as physically, you know.
Yeah. Yeah, my parents are great people. I think they just kind of set that bar high of like, this is how much you can accomplish in life. And I think just like having, again, like them as role models has been really something to aspire to.
So do you have brothers and sisters?
Yes, I do. Yeah. I have, there's like 3 girls and 2 boys. So,
And are both of the boys in the profession also?
I mean, there's no one who else is like a nurse or a doctor, but you know, we have like one of my siblings does like healthcare law, and then another one is a registered dietitian.
Okay.
So there's kind of different
So
aspects of the medical field.
Yeah, but it is in a
Correct.
medical field
Correct. Yes.
because it improves health.
Yes. Yeah, and it
For
kind
everyone.
of goes into that whole person care, you know, all the different aspects in order to have all the different disciplines in order to really provide, you know, complete whole care.
This has been a very interesting conversation.
Thank you.
So what are we going to hone in now toward the end? Do we have something specific?
Sure, sure. Well, I think we talked a little bit about, palliative care, the differences between palliative care and hospice care. We talked about, who we are as nurse practitioners and kind of what our role is
And
in,
how you got into the profession?
yeah, and how we got into the profession. We work at Providence Holy Cross, which is a fantastic hospital. Very whole person hospital. We're very, involved in the hospital, integral into the care of patients. And, what I would say is that hospitalized at the hospital and come into contact with our team, that, palliative care is really there to meet you where you're at, to make sure that you're cared for as an individual, what your goals are and what's important to you. I would say something to the community that's important is to, we don't want to think about these things that often. It's hard to talk about sometimes, but something very important is to discuss your family. God forbid if you were in that position, to complete an advanced healthcare directive, naming who your decision makers might be and what your medical wishes might be in the event, God forbid, that you were in a situation like this. That will make it, even though it's never going to be easy, that will make things a little bit simpler on yourself and your family. God forbid if you're ever in a situation like that. So, to the community out there, I would say, we never know what might happen in our lives, and to just be prepared for anything that might happen, and to discuss that with your family.
Can I ask, like, okay, so a medical directive, does that have to be something in writing? Like, where
Yes.
where is the bureaucracy in that? Like, what did
Yeah.
the hospital administration needs something in writing that's prepared
Yes.
in case of this, right?
Yes, so it's actually called an advanced directive,
Yeah.
and you can, download a copy online and print it out. Specifically, it's who you would want your medical decision makers to be if you are unable to make your own decisions. And then it goes into a little bit about what your wishes might be
Right.
around
Extraordinary
life support,
measures, yeah.
and things like that. It is signed by 2 witnesses that are not the people that you named as your decision maker, or it can be notarized. And then whichever's easier. And then you could take a copy to your doctor's office and just have them scan it into your medical record. And then you could simply put it away, and then it's, there just in case it is ever needed in the future.
Okay, and circling back again, I'm sorry, because
No,
this is
that's okay.
real. What if there is a case of dementia without an advanced directive? So, then how does that work?
Correct. So in the case
Power
of
of
dementia,
attorney?
obviously you can't sign
Yeah.
for yourself and
Right.
things. So I would be hopeful. No one knows what's going to happen. You have to do this while you have capacity of mind.
Right.
But if you haven't done it, then we gear patients towards a form called a POLST form. That's a bright pink form. It stands for Physician's Orders for Life-Sustaining Treatment. And that would need to be filled out by your next of kin. And then that would go into your medical wishes around resuscitation, around different levels of medical care, and around artificial nutrition.
Yeah,
So
again, it's a difficult conversation, but
it is necessary.
you have to do it before it's there, right?
Correct. No one knows the future.
Yeah.
Everyone hopes for the best, but we always want to be prepared. And it's a kindness for your family that your family knows that these are your wishes and this is what you want. And in some ways, it takes that burden off of them to guessing what you might have wanted in this situation.
Yeah.
So if I can leave, the community with something, that's what I would leave you guys with, just to make sure that that's completed. So that way, we could care for you the way you would want to be cared for.
Right, and it's as simple as doing a Google search, advance directive,
Yes.
and you'll have a legally binding form there.
You'll have a form to fill out, and it works as a guide.
Yeah.
It works as really a guide for us in healthcare as to what you would want in those situations.
So Hannah, does your family, your entire family in the medical profession, do they all have advanced directives?
My parents do, but I don't think all of my siblings have advanced directives. But, I think through this clinical rotation, I think that's something even I started to think about, right? Like, being proactive and just not having to have my family worry about what decision I think they think I would make for myself.
So are you willing to talk with your sisters and brothers
Yeah.
and sit down with them? Are they amenable to that?
Yeah.
Or have they even thought about it yet?
Some of them live out of the state right now, but I think, that's something that we, we're a very close family. I think that's something we would have a conversation about sooner rather than later, obviously, as Sandra had mentioned.
Yeah,
Well,
I think
thank you
that's-
both
yes.
for taking time
welcome.
out of your schedule. I know it's daunting. There's a lot to make happen in a nurse practitioner's life. Thank you for being here.